আমরা শুরু করি স্যার।
জি স্যার, আমরা শুরু করতে পারি এখন।
Assalamu alaikum. On behalf of National Heart Foundation Hospital and Research Institute, I take the opportunity to welcome all of you in our today's live inbox session. Last week, 15 days back, we had a look at a pacemaker procedure live, which was performed by Professor Ashok Dotto. Probably to make it a bit more clear and up close, today we have again arranged a class session of live inbox on pacemaker. Today we are with us two excellent speakers, Dr. Shamim Chaudhary, Registrar of National Heart Foundation Hospital and Research Institute, and Professor Mir Nesaruddin Ahmed. Both of them are very passionate about pacemaker, and Nesar sir obviously is very passionate about teaching different aspects of pacemakers to our students and always giving interesting anecdotes in our Viber group. And I'm sure very shortly we will be joined by Professor Attahar Ali, who is the pioneer in establishing electrophysiology as a super specialty of cardiology in Bangladesh. And I'm sure very shortly we have with us already Professor Badiuzzzaman sir, Professor Dhiman Bonik sir, and I'm sure Nazir Ahmed sir and Professor Fazila Malik will be joining us shortly. Without any delay, I would like to request Dr. Shamim Chaudhary to start his lecture. He will be speaking on the basics of pacemaker, indications, contraindication, lead system, and coding, etc. Dr. Shamim Chaudhary, you may share your screen.
Am I visible, sir?
Yes, you are audible and your screens are visible. Please start your presentation.
Respected panel of experts.
Go to slide share, please. Go to slide share.
Is it not visible yet?
Visible slide share যান, না হলে তো নিচে slide share ক্লিক করেন।
স্যার সাহেব স্লাইড শোতে ক্লিক করেন।
হ্যাঁ, না আপনি শেয়ারিং অফ করে দিলেন তো। এখন নিচে স্লাইড শোতে যান।
এটাই।
Okay, perfect. Thank you.
Respected panel of expert, moderator, and distinguished guest, Assalamu alaikum. My topic of presentation is the basics of the permanent pacemaker implantation. A cardiac pacemaker is an electronic device that delivers direct electrical stimulation to the myocardium to depolarize and initiate a mechanical contraction. However, it works whenever the heart's natural pacemaker is unable to do so. Pacing may be accomplished through a permanent implantable system or by a temporary system with an external pulse generator and percutaneous threaded leads, or a transcutaneous external system with electrode pads placed over the chest. The generation of the pacemaker started from the 1958 when it was first external pacemaker was implanted, followed by 1960 there will be first implantable pacemaker, and it followed by 1989 the dual chamber rate responsive pacemaker, and followed by lastly the latest version of the pacemaker, that is leadless pacemaker, on 2015. Different methods of pacemaker cardiac pacing are the transvenous, epicardial, and the leadless pacing. And the types of pacemaker, there are asynchronous or synchronous mode, and the single or dual chamber, sequential or multi-site biventricular pacing, programmable or non-programmable pacemakers. The basic components of the cardiac pacemaker are the pulse generator, lead system, polarity, and lead heart interface. And the pulse generator contains usually the output circuit, the sensing circuit, the timing circuit, the telemetry coil, microprocessor, and sensor circuit for rate adaptive pacing. Regarding the lead system, it has 4 parts, that is terminal pin, lead body, stimulating and sensing electrode, and fixation device. The lead system usually are 2 types, bipolar and unipolar. Bipolar leads has the both negative and positive electrodes within the heart separated by 1 centimeter. It has larger diameter and more prone to fracture, compatible with the ICD. And the unipolar leads are in which their negative electrode are in contact with the heart, but the positive electrode is within the pulse generator. It has prone to the more oversensing, but not compatible with the ICD. This is a pictorial of the unipolar leads, which have larger spacing spike, more than 20 millimeter. And this is a bipolar lead, which with the small spacing spike less than 5 millimeter. And the leads are being fixed in the atrium and ventricle through two mechanisms, either by passive fixation or active fixation. Passive fixation represents an attachment mechanism by the tiny leads that encodes the electrodes to the endocardial trabeculae. And active fixation leads are secured to the endocardium using a screwing mechanism. Now the single versus dual chamber pacemaker. The advantages of the single chamber pacemaker is its implantation of a single lead, less expensive. The disadvantage is that there is loss of AB synchrony, and single atrial lead does not provide ventricular backup if A to V conduction is lost. But there is no all-cause death benefit in case of dual chamber or single chamber pacemaker. However, there is a benefit in case of stroke and embolism prevention from atrial fibrillation, hospitalization, but hospitalization for heart failure there is no benefit. But there will be benefit from the exercise capacity and pacemaker syndrome. Exercise capacity will be increased, and there will be less chance of pacemaker syndrome in case of dual chamber pacemaker. However, more complications with the dual chamber pacing. Now the coding system, the revised North American Society of Pacing and Electrophysiology and British Pacing and Electrophysiology group has developed 4 coding systems that was modified on 1992. Usually the most commonly used coding system are the 4 coding systems. That is, first one is the chamber pace, second one is the chamber sense, third one is a response to the sensing, either triggered or inhibitor, and fourth one is the rate modulation. And fifth one is used in case of anti-arrhythmia pacing, anti-arrhythmia device, that is multi-site pacing. Nowadays it is rarely used. Now the pacing modes, the commonly pacing modes are, there will be VVI mode. It was used in case of chronic atrial fibrillation. There will be AI mode in case of sinus node dysfunction with normal AB conduction. AI mode is the mode of choice. There will be VOO or AOO mode, that is asynchronous pacing modes. It is used in case of either in case of surgery or any diathermy use. VDD mode in patients with normal sinus node function with AV block. And DDD mode, that is the commonly used mode, that DDD pacemaker senses and paces both the atrium and ventricle, and the response to sensing involves both inhibition and triggered activity. Now the steps of the permanent pacemaker implantation, there will be some pre-procedure checklist followed by the local anesthesia, followed by the lead insertion routes, either by cephalic route or subclavian or axillary route, followed by the making of the pocket, and followed by the lead positioning, the ventricular and atrial leads. Then after that, the testing of the lead function and stability, followed by wound closure, post-procedure care, and the follow-up. Now the indications of the permanent pacemaker. In patients with persistent bradycardia, the class 1 indication is the acinodal disease with persistent bradycardia, the class 1 indication. And the acquired AB block, that is either third or second degree type 2 AB block, there will be class 1 indication. Indication of cardiac pacing in case of bundle branch block. The patient with bundle branch block with unexplained syncope and abnormal electrophysiology study is a class 1 indication, or alternating bundle branch block with or without symptom is a class 1 indication. Indication of permanent pacemaker in case of intermittent bradycardia. The class 1 indications are the acinodal disease, including tachybradyform with the symptomatic bradycardia due to sinus arrest or sinoatrial block. That is a class 1 indication. Or intermediate or paroxysmal AV block, that is intrinsic third or second degree AV block, including the AF with slow ventricular rate, is a class 1 indication. Now the most commonly asked question, that is the indication of cardiac pacing in acute myocardial infarction. For the permanent pacemaker implantation, the patient with after ST elevation MI or the symptomatic patient with chest pain, if the patient have persistent complete third-degree block or advanced second-degree block that is associated with block in the His-Parkinson system characterized by the white QRS complex in the ECG. And another class 1 indication is a transient advanced second degree or complete heart block with a new bundle branch block. Another non-cardiac indication of permanent pacemaker is the carotid sinus syndrome, syncope. The pacing is indicated in patients with dominant cardio-inhibitory carotid sinus syndrome with recurrent unpredictable syncope. Now, the pacing after cardiac surgery or TAVI or heart transplantation. The class 1 indication are high degree or complete AV block after cardiac surgery and TAVI, and the sinus node dysfunction after cardiac surgery or heart transplantation. However, in this case, we have to observe the patient for up to 5 to 7 days, whether the rhythm disturbance is transient or resolves, whether it is persistent. Now, the pacing mode in case of different type of diseases, like in case of sinus node disease, in case of persistent AV block, DDDR is the first of choice. But in case of AV block, as sinus nodal disease, DDDR is the mode of choice. But in case of atrial fibrillation, VVIR is the choice. Now the complications, the acute complications of the pacemaker implantation are the pneumothorax, hemothorax or air embolism, pacemaker pocket hematoma, cardiac or central vein perforation, diaphragmatic stimulation, local muscular stimulation, pacemaker malfunction, lead dislodgement or damage. And the chronic complications of the pacemaker implantation are the pacemaker system infection, intravascular thrombosis or obstruction, Twiddler syndrome, pacemaker mediated tachycardia. Thank you for the patient here.
Thank you, Dr. Shamim, for your brilliant and short presentation. Actually, what you have presented is probably one of the most important things that are going to be asked in the exam table, where at the initial stages of when you are given the pacemaker as an instrument. So I'm sure the students will be benefited for this. So now the live in box case will be demonstrated by Professor Mir Nesaruddin Ahmed. Sir, you can please share your screen.
Okay.
Right, sir. You are visible and your screen and you're audible as well, sir.
Thank you very much, Dr. Tawfiq, and Assalamu alaikum and good evening to everybody, distinguished panelists, moderators, and attendees. Today's my presentation is pacemaker implantation technique live in the box. Initially, in the development from the 1958 for many years, it was the pacemaker was implanted only by the cardiac surgeon, but later on, with the development and advancement of the pacing hardware system and venous catheterization system, ultimately it comes into the cardiologist. And now most of the cases and everywhere, cardiologists are implanting the pacemaker. So I will start my presentation with brief. Just already Dr. Shamim pointed out in which aspect we are implanting the pacemaker, that is pre-procedure checklist, and then local anesthesia, and then lead insertion in various routes, and ultimately making the pocket, then lead positioning ultimately in the ventricle and as well as in the atrium, and finally testing the lead and functional stability, and final closure and post-operative care, and ultimately follow-up in the long run. So first of all, the patient preparation is the important things. Just a minute. Informed written consent should be obtained from the patient, and it should be briefly, it should be benefit should be honestly discussed with the patients and patient's family as well, especially regarding the indication, and thoroughly describe to the patient, especially and the need for lifetime follow-up and should be emphasized. The patient should be informed about the generator change subsequently and possible lead replacement in future. And sometimes there may be some physical or occupational restriction related to the patient, including rules regarding the driving, especially during the first few months as well, and discuss the later with the patient. And then routine pre-implant lab test, including 12 ECG, chest X-ray, complete blood count, INR. Sometimes patient may have with anticoagulant. In that case, we have to regarding the INR and serum electrolyte. If there is an electrical imbalance, patient may develop arrhythmia during the implantation as well, and blood urine nitrogen and creatinine level as well. And many of the patients regarding the pacemaker would be on a oral anticoagulant. In that case, sometimes when the patients have or anticoagulant, it's really challenging. Previously, when patient was on warfarin and it was discontinued for 48 hours before implantation procedure and within the intervention heparin. But nowadays, it's not practicing. Nowadays, pacemaker implantation done without reversal of the anticoagulant, and this practice all associated with lower risk of pocket bleeding and shorter hospital stay as well. And what are the equipments we are using during implanting the permanent pacemaker, especially the electrophysiology laboratory, or it may be catheter laboratory, or with the operating room, and pacemaker implantation by the interventional cardiologist or electrophysiologist or catheter laboratory use resulting in a significant reduction in the medical cost and as well as hospital stay. And minimum required person, especially implanting cardiologist, one scrub nurse and one circulating nurse or technician. Scrub nurse is required to help the planter throughout the procedure, and circulating nurse or technician is required to prepare the and administer medication and to operate in the pacing system analyzer to programming the pacing system. And fluoroscopy, of course, fluoroscopy and electrocardiography are necessary equipment in every device implant. And usually, anterior posterior or 30-degree RO or 40-degree left anterior oblique view is usually required for transverse implantation from either the side right or left approach. Initial lead sensing and capture measurements are obtained by pacing system analyzer, which may be stand-alone or built into the pacing program. And fluoroscopy, in addition to fluoroscopy support, we can all have the vital observation monitor, that is cardiac monitor, and number of sterile surgical instruments, equipment that are needed, and surgical materials, including absorbable and non-absorbable material, and lead and device encoding absorbable materials, and antimicrobial flush and saline for pocket irrigation should be available. And if nanogram, sometimes it may be needed, and appropriate intravenous contrast agent must be available. And this is the trolley preparation in our daily practice, and with essential instruments. The different types of instruments here. That is from the BP blade, then carburetary forceps, that is tissue cutting scissor, and different forceps and scissor, needle holder, and the tissue forceps. Tissue forceps, and there is our forceps, and there is a right angle detector and master detector as well. And these are the puncture set for central venous access in our daily. And anesthesia, usually we use 1 to 2% lignocaine, and it is sufficient for doing the permanent pacemaker implantation. But sometimes we may need conscious sedation, especially midazolam, or sometimes fentanyl may be used. And on rare occasion, general anesthesia may be required in an extremely uncooperative patient. Antibiotic prophylaxis, especially, most platters prefer to give oral or intravenous antibiotic to decrease the incidence of local or systemic infection. In our daily practice, we usually use 1 gram ceftriaxone IV preoperatively and 1 gram vancomycin either in the dry form or in the diluted form, and 1 ampoule gentamicin inside the pocket pre and paraoperatively. And patient placed on the table and on the back on the arms stuck and tucked. Physiological monitor, that is ECG, pulse oximeter, and NIBP should be quickly established to detect any source of arrhythmia or hemodynamic abnormality during the procedures. And preparing the implant field is also crucial to minimize the complication. Still, it is very obviously a paramount importance, and chest is prepared with an antiseptic solution, and the area is covered sterile wraps to keep the incision area as clean as possible. And there are different access route for central access to implanting the lead in different areas, the jugular vein, especially we usually cephalic vein or axillary vein or subclavian vein. And implant area is the pictogram or surface marking we can use or tail, where we can implant to the deltopectoral group or easy access to the cephalic vein in dissection method or in the IB route, intervenous access route. And the access sheath and needle to penetrate the central venous. And sometimes, usually, in our daily practice, we use we do order angiogram, and during the time we use the hanogram to detect venous route access site. And sometimes there may be persistent superior phenocoma. In that case, it will be more easier to choose on the other side, that is usually right side. And this is the area where the first rib and clavicular to access the subclavian artery, subclavian vein, and the subclavian vein, and axillary vein, and cephalic vein as well, the central venous access, and the again, there is surface marking. There is medial to the actinic process and that interposterior the fluoroscopy to access the subclavian vein. And pocket incision, usually it's a different issue, different practice and individual. Somebody use the deltopectoral and oblique carved incision, and somebody use horizontal incision, just middle third of the clavicle, and someone is oblique use. I usually prefer horizontal incision, just middle third of the clavicle. And then my particular point is that I can extend the incision site medially if needed, or you can do laterally if needed. And the pocket area, cleaning the area from the root of the neck to the mid chest bilaterally. And this is the process going on both sides. Then with draping, and we usually use I1 to cover the operative area. Purpose. And after cover the area, is complete. The slide is moving, perfect. And then give Look say 2% lignocaine. The lignocaine to infiltrate the local anesthetic purpose, the operative area. And puncture the we try to do except for the concept of the axillary vein or sometimes subclavian vein more medially. The puncture is done. Second puncture. Okay. And already guide was introduced into the area. As because the patient is having so you did two puncture here for atrial and ventricular access.
Most of the time, almost 99% cases আমরা single ear আমাদের থেকে
Then wire incision. That's it through the needle. And ultimately pocket creation, with the blunt dissection. This is the master detector. We have the two wire for accessing to the ventricular and as well as the right atrial lead. With the blunt dissection, the artery forceps. These are simple baby blade for making incision, and ultimately we pulled out the wire inside the cutting area. And making the pocket. The diathermy to problem the bleeding point. Oh, the pocket is okay now. And we give adrenaline mixed roll of one roll gauze to for hemostatic purpose and making the dry in the pocket. And ultimately lead insertion to the hospital access sheet. Lead is inserted. Now the feel of the sheath. I'm sorry for the sound. Now inserted. And particularly this lead usually introduced by the single hand is possible, and it's usually prevent air entry into the pulmonary artery.
লক করে নিয়ে আগে তারপরে লক করে নিয়ে আগে
Now lead is placed across the tricuspid valve with the RV of the upper septum, and assessing all the parameters, including R wave, sensitivity, threshold for placing them, and optimum placing. Lead is placed in the upper septum. If we turn the fluid scope on left entry oblique view 35-degree angle, in that case, the lead is placed toward the vertical column, direction that is towards the vertical column. Here you can see the lead is placed in the upper septum. And if we look at the ECG, the lead, inferior lead shows upright, the R wave, and early transition.
It is in septum.
Early transition that is in the V3 level. If we go to the upper septum, the RVUT. And we can place the lead across the RV apex, low septum, mid septum, high septum, and of course, and if possible, the RVUT as well. These are the schematic presentation where lead is placed across the RV apex, then in the mid septum, and the upper septum, and the RVUT. RVUT is placed in the atrial septum or maybe the free wall. And we can sometimes we can use, that is most Apple's type, there is U shape, then to some extent secondary curve, the primary curve, to place the lead across the septum. But it's not mandatory to use this curve. It depends upon the practice. I usually use only U-shaped curve to place the lead in the septum. And we can assist the lead position, the lead as well as with the comparing with the ECG as well in different setting. That is RV free wall, septum, or RV apex by seeing the ECG. There is the RV apical system or the LV pattern. The RV septum. It is the early transition, and there's a free wall, late transition, B5, B4 negative, there is a B5 late transition, and B6 positive, and there's a nose in the dominant ROF 2-3 ABF. This indicates the RV free wall lead position. Now the lead is placed in the here is the RV apex lead. The actual lead position through the preformed curve, and sometimes it needed some modification. It depends upon the individual right atrial appendage. If there is a right in that case, we can use right atrial lead across the interatrial septum or in the corner, most of the coronary sinus for atrial lead. And the different shape and position of the RV lead, and the lead, ultimately the lead fixation with the silk, as because it is the tried permanently, then lead fixation again, and ultimately generator connection. There is the generator, and there is the port for atrial lead, and there is a ventricular lead, and ultimately pocket axis lead length to ensure axis lead length placed behind the pacemaker. So leads are positioned properly and tested, and central sistered the underlying tissue, and pacemaker irrigated with antimicrobial solution, and the pulse generator connected securely leads. Operation is confirmed. Final look under the first script before the closure of the incision is recommended to confirm the appropriate lead position, and then ultimately the closing the incision here, and the final closing after closing the surgical area. Sometimes, if we initially use the dissection method to find out the cephalic vein across the delta capital group, but nowadays we are using central venous puncture technique. So then ultimately, the incision is closed by layer with, especially the deeper tissue with abdominal suture material, and the skin with the silk, and then still dressing the applied across the surgical area. And post-surgical, usually pain is very minimum. Sometimes patient can give pain medication, or then we use IV or all antibiotics after the procedure according to physician's choice. Sometimes post-operative chest radiography is usually obtained if there is a chance of pneumothorax there. And before discharge, we can use to access, that is posterior lateral chest radiograph, especially right lateral view, the deep penetrating view, to confirm the lead position and ultimately exclude the delayed incidence of pneumothorax. And finally, interrogation also recommended to ensure proper pacing function before patient leaving the hospital. And common complication already showing told with the common chronic complication. And battery power, usually initial stage, it is in 2.8 volt, and subsequently then end of life will become less than 2.1. In that case, all the functions may be not working, or special may generator may be turned into the simpler mode, that is only VO, and sometimes communicate may not be able to communicate with the pacing system analyzer as well. So thank you very much. Thank you for patient hearing.
Professor Mir Nasaruddin Ahmed, thank you very much for that very excellent step-by-step demonstration of pacemaker procedure. I think our students, if they have attended attentively, have a good idea about what to do afterward in pacemaker during a procedure which is usually asked during the exam. Do we have Atar Ali sir with us?
আপনার স্যার তো
এই নম্বরটি এখন ব্যস্ত আছে। The number is
Sorry.
busy.
Okay, and so there is a
maybe
question-
busy in the catholic.
So there is a question in the chat box, which is what is VAT and VDD and DVI mode and VDD mode? Application of magnet to the pacemaker generator. These are another question. So what is the VDD and DVI mode? I don't know if I got the question correctly. So would you kindly check the chat box, question answer box, QA box?
VDT. What is ventricular activation time?
Right.
What is that ventricular activation time? VDD and DVI mode and VDD
And
mode.
VDD mode.
VDD mode, if the patient has been up with intact sinus node, in that case, we can use VDD mode. But most of the time, if you use DDDR, that is the most as because even in six-sided syndrome, we usually like to use DDD mode. Initially, though, it was placed AI only AI pacemaker, but nowadays we recommend dual chamber pacemaker as because patient having six-sided syndrome, sometimes more than 50% case almost associated with AV nodal block, or in course of time, patient may in future may develop AV block. In that case, it should be upgrade the pacemaker if we use a single chamber, that is AI. But so that if we used dual chamber pacemaker, that will be better in future.
An application of magnet to the pacemaker generator. What is the importance of applicating a magnet in the pacemaker generator, sir?
Usually, every pacemaker have an individual magnetic rate. It is usually almost 99 or 100, anything else. In that case, especially in the end of life, in that case, or the pacemaker is properly working is not. But if the patient own rhythm, that is rate below 100 or below magnetic rate, in that case, we can apply them. If we apply the magnet, we can ensure that whether pacing is working properly or not. Or if the end of life, in that case, we can use magnet to detect whether how is the battery is working and how is the life is there by seeing the magnet rate. As because magnet rate gradually depleting with the battery depletion, magnet is usually gradually decreasing in future.
So there is another thing which you always say after implanting a pacemaker, what is the hysteresis rate and what is non-hysteresis? So would you like to answer that also, sir?
Hysteresis একদম সহজ ভাষায় বলতে গেলে যে আমরা যখন পেসমেকার করি জাস্ট টু সেভ দ্য ব্যাটারি লাইফ অথবা পেশেন্টকে আনইউজুয়াল পেসিং থেকে করার জন্য, যে পেসিং যাতে না লাগে, যতটা আপনি করা যায় ইন্ট্রিনজিক রিদমটাকে যতটুকু এনকারেজ করা যায়, সেই ক্ষেত্রে আমরা হিস্টেরিসিস অন করে রাখি। সে পেশেন্টকে আমি হিস্টেরিসিস অন করে হয়তো 10 বেস রেট আমি 60, হিস্টেরিসিস 10 করে দিয়ে ড্রপ করলাম আমি 15। দ্যাট ইজ পেশেন্টের যদি হার্ট রেট 50 নিচে যায়, 50-তে যায়, তখন সে পেস করবে, এবং ঠিক সে পেস করবে কি 60 রেটে সে পেস করবে, যে তার হিস্টেরিসিস আমি 10 ড্রপ করে রাখছি, আদারওয়াইজ সে পেস করবে না। এখানে অনেক সময় দেখা যায় পেশেন্ট এই ফর দ্য টাইম বিং few seconds patient may develop patient may feel palpitation only. That's because patient initial rate was 50, now it is 60. Within second, patient may feel some sorts of palpitation as well. So history is important, especially to save the battery life and to encourage the intrinsic rhythm as well.
So there is also another question, sir. What is the difference between LBB and LBB induced by RV pacing?
ডক্টর হারুন, তুমি এটা আনসার দিবা। তোমাকে সকালে বলেছি আমি, এখন বলো।
স্যার আপনি কি ওকে কোশ্চেনটা করতে বলছিলেন না আনসারটা জেনে আসতে
না
বলছিলেন?
ওকে আমি তখন আমি যখন পেসমেকার বসাই ইমপ্ল্যান্ট করছিলাম, আজকে 2টা পেসমেকার বসাই, তখন আমি ওকে বলেছিলাম যে ইন্ট্রিনসিক এলবিবি আর এলবিবি ডিফারেন্সটা কি। তারপর বলো হারুন, বলো উত্তর দাও।
ও তো স্যার দিতে পারবে না, প্যানেলে নাই। আপনি দিয়ে দেন স্যার। ও চালাকি করলো স্যার।
হ্যাঁ, ওকে বলে দিয়েছি, তখন বলেছি, ওকে বলে দিয়েছি আমি।
স্যার আপনি আমাদের সবাইকে বলে দেন স্যার।
হ্যাঁ, এখানে হলো আর্লি অ্যাক্টিভেশন সেপ্টাবলে
বন্ধ করে দাও।
আর্লি
চলে যান বাবা, চলে যান, চলে যান, চলে যান।
সাধারণত এলবিবি পেসিং ইনডিউস এলবিবি তে আর্লি অ্যাক্টিভেশনে যে হয় সেখানে, আর ওটা লেটে অ্যাক্টিভেশন হয়, বিশেষ করে সেপ্টাল এবং ইন্ট্রাল পার্ট, ইনিশিয়াল আর্লি পার্ট। দ্যাটস দ্য মেইন ডিফারেন্স।
শামিম, ইউ আর
আমার
ট্রাইং
একটা
টু
কোশ্চেন আছে, তবে
স্যার।
আমার একটা কোশ্চেন আছে, আমার একটা
স্যার।
কোশ্চেন আছে স্টুডেন্টদের জন্য।
স্যার আজকে
বলবি?
তো স্টুডেন্টরা আনসার করবে না আজকে।
না আমি না
নেসার স্যার বা অশোক স্যার
স্টুডেন্টদের
আনসার করবে।
পারপাসে আর কি, না স্টুডেন্টদের পারপাসে। নেসার ভাই, আপনি
অশোক স্যার,
স্টুডেন্টদেরকে একটা কোশ্চেন আনসার একটু ক্লিয়ার করে দেন। অ্যাট্রিয়াল ফিব্রিলেশন আছে, এখন কোন ধরনের পেসমেকার ইউজ করবে এবং কেন?
পৃথিবীতে একমাত্র ইন্ডিকেশন আছে এখন সিঙ্গেল চেম্বার পেসমেকার, দ্যাট ইজ অ্যাট্রিয়াল ফিব্রিলেশন।
ইয়েস,
হ্যাঁ, অ্যাট্রিয়াল, আদারওয়াইজ আর কোনো ইন্ডিকেশনে সিঙ্গেল চেম্বার পেসমেকার ইউজ করা।
এই স্টুডেন্টদের কিন্তু এটা খেয়াল রাখা লাগবে।
Chronic persistent atrial fibrillation, only one single indication. For
আচ্ছা,
implant-
next question হচ্ছে what is synchronous pacing, what is sequential pacing? এটা একটু ক্লিয়ার করা লাগবে স্টুডেন্টদেরকে।
এটা স্যার আসলে ইসিজি না দেখালে
না দেখে
বলা
ওগুলা
খুব
করবে না।
ডিফিকাল্ট। হ্যাঁ,
Sequential
Okay.
simultaneous atrial এবং ventricular pacing, that is sequential pacing.
আচ্ছা,
Atrial pacing হলো প্রোগ্রাম এবি ডিলের পরে সে ভেন্ট্রিকুলার পেস করবে, আর সিনক্রোনাস পেসিং এ সে এবি অ্যাট্রিয়াকে সেন্স করে এবি ডিলের পরে সে কিউআরএস কে পেসিং করতে পারে, এতে সিনক্রোনাস।
মানে স্যার আপনি পি এর আগেও স্পাইক পাবেন, কিউআরএস এর আগেও স্পাইক পাবেন, তখন এটা হচ্ছে
দ্যাট ইজ সিকোয়েন্সিয়াল।
দ্যাট ইজ
এটা sequential pacing, yes.
স্যার। একটা থাকলে দ্যাট ইজ সিনক্রোনাইজড।
হ্যাঁ,
স্টুডেন্টরা
এই
বুঝতে পারছো?
হ্যাঁ, এই জিনিসটা মনে রাখতে হবে।
আমি বলছি নেসার ভাই থেকে এটা ক্লিয়ার করে আমি
মেবি স্যার আমরা কোনো একদিন ক্লাসে শুধু ইসিজি পেসমেকার রিলেটেড ইসিজি কিছু দেখাতে পারি, দেখালে
এখনকার সময় যেটা হয় যে ইউজুয়ালি এই ধরনের কোশ্চেন গুলা এই মুহূর্তে তো মানে পাস করার জন্য এমডি লেভেলে ধরা হয় না, তবে যেহেতু এখন এই পেসিং গুলো হচ্ছে মানে আগের চেয়ে অনেক ডেভেলপড স্টেজ এখন পেসিং হচ্ছে, যেমন সেপ্টাল পেসিং হচ্ছে, হিজ পেসিং হচ্ছে, কাজে এই ক্ষেত্রে কিছু জিনিস জানতে হবে অনেক সময় ভালো মার্ক ক্যারি করার জন্য, যে অনেক সময় কোশ্চেন করতে পারে সেপ্টাল লিডে আমি সেপ্টামে প্লেস করলে আমার ইসিজি কেমন হবে, আমি মিড সেপ্টামে করলে কেমন হবে, আরবিওটি তে করলে কেমন হবে, এগুলো একটু জানা দরকার আছে ভালো
এটা জানা লাগবে। এটা
ভালো নাম্বার ক্যারি করার জন্য।
স্যার যেমন স্যার একজন ডক্টর হারুন আবার জানতে চেয়েছে ভালো নাম্বার পাওয়ার জন্য মাল্টি সাইট পেসিংটা কি?
মাল্টি
মাল্টি অশোক বলেন।
স্যার
না, না।
প্রফেসর অশোক স্যার।
না বলেন 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 বলেন
বলেন।
না
প্যানেলিস্ট।
না আমার কোশ্চেন ছিল একটা, যে এলবিপি তে আমরা দেখি যে কিউ থাকে V1 2 3 এ কিউ থাকে, V5 V6 এ ওয়াইড কিউআরএস ওয়াইড আর থাকে, কিন্তু পেসিং স্পাইক যখন আসে মানে পেসমেকার দ্যাট প্রোডিউস দ্য এলবিবি, সেখানে ট্রু অ্যান্ড ট্রু ফ্রম V1 টু V6 আর থাকে না, সব জায়গায় শুধু কিউ থাকে, কেন? নেসার ভাই,
হ্যাঁ,
আরবি পেসিং এ এলবিবি প্যাটার্ন হয়, কিন্তু এই এলবিবি প্যাটার্ন
এখানে তো নরমাল যে পেসিং হচ্ছে সেখানে তো বেস টু অ্যাপেক্স হয়, আর এখানে অ্যাট্রিয়াম আমার যখন পেসমেকার দেওয়া হচ্ছে তখন আমার অ্যাপেক্স টু বেস পেসিং হচ্ছে, দ্যাটস দ্য ইম্পর্টেন্ট থিং, অ্যাপেক্স টু বেস।
আচ্ছা, এখন হারুন কি জিজ্ঞেস করছে মাল্টি
সাইট পেসিং কি স্যার?
আচ্ছা, মাল্টি সাইট পেসিং হচ্ছে যদি একাধিক জায়গায় আমরা পেসিং করি, সেটা ইউজুয়ালি যেটা হয় এলবি পেসিং, যেটা সিআরটিপি বা সিআরটিডি এর ক্ষেত্রে এলবি তে যে লিড থাকে, লিডে দেখা যায় মাল্টিপল পোল থাকে, কোয়াড্রিপোলার হয়, কোয়াড্রিপোলার মানে 4টা পোল থাকে টিপ থেকে শুরু করে। আমাদের এখানে আরবি পেসিং যেটা করি সেখানে তো কোনো পোল নাই, মানে শুধু টিপ দিয়ে আমরা পেস করছি, ওখানে টিপ দিয়ে পেস করা যেতে পারে, পরপর আরো 3টা পোল থাকে, যে কোনো জায়গায় দিয়ে পেস করা যেতে পারে। অনেক সময় দেখা যায় একটা সাইডে পেস না করে 2টা পোল বা 3টা পোল থেকে পেস করা হয়, মানে larger area of the LV is placed at a site at a time. এটাকে বলা হয় মাল্টি সাইট পেসিং। That is not true for normal pacemaker, that is true for biventricular pacing.
হ্যাঁ, only for biventricular pacing। যেমন যেমন কোয়াড্রিপুলারে 16 ভেক্টরে এটাকে অ্যানালাইজ করে সেট করা যেতে পারে। এগুলো সাধারণত ওই লিড প্লেসমেন্টের জন্য অনেক হেল্পফুল হয় বিশেষ করে।
স্যার স্যার কোয়েশ্চেন আনসার বক্স আরো কিছু কোয়েশ্চেন এসছে স্যার, নেসা স্যার যদি
হ্যাঁ, মাল্টি সাইট হয়েছে কমপ্লিট এবি ডিসিশন এন্ড এবি ব্লক। হোয়াট ইজ কমপ্লিট এবি ডিসিশন? হোয়াট ইজ এবি ব্লক? এবি ব্লক ইজ এবি ব্লক, কন্ডাকশন ইজ নট
ফার্স্ট সেকেন্ড থার্ড ডিগ্রি যে কোনোটাই হতে পারে, আর থার্ড ডিগ্রি
হ্যাঁ,
হচ্ছে এভিডেন্সিয়েশন।
এবি ডিসিশন অল এবি ডিসিশন ইজ
আর
নট এবি
এবি
ব্লক।
ডিসোসিয়েশন যেটা হয়, যেমন ভিটির ক্ষেত্রে কিন্তু এবি ডিসোসিয়েশন থাকে, বাট দ্যাট ডাজ নট মিন দেয়ার ইজ এবি ব্লক। সো এবি ব্লক এবি ডিসোসিয়েশন হতে পারে। এবি ডিসোসিয়েশনের আদার একটা কারণ হতে পারে ভেন্ট্রিকুলার ট্যাকিকার্ডি।
স্যার বাইভেন্ট্রিকুলার পেসিং এর ইসিজি ক্রাইটেরিয়া জানতে চাচ্ছিল কামরুল।
অস্পিতে সব এটা বলা হবে না এখানে, এটা তো আরেকটা পার্ট হবে, হবে তবে এটা দেখা উচিত। হ্যাঁ, 1 AVL এ কি লিড থাকে, কি পজিশন হচ্ছে, V1 এ কি হচ্ছে, আরবি পেসিং, আরবি থেকে এলবি পেসিং থেকে আরবি পেসিং এর ডিসটেন্স কতটুকু হচ্ছে, বা ভেন্ট্রিকুলার অ্যাক্টিভেশন টাইম, এগুলো অ্যাসেস করে বলা যেতে পারে। এগুলো তোমার শুধু ওই ক্রাইটেরিয়া দেখে করবে না, চোখে দেখতে হবে, বারবার দেখতে হবে। বাইভেন্ট্রিকুলার পেসিং ইসিজি না দেখে বুঝতে পারবে না। 1 AVL নেগেটিভ ধরে নেওয়া যেতে পারে যে তার এলবি পেসিং হচ্ছে, আর কিউআরএস কমপ্লেক্স ন্যারো হবে ইউজুয়ালি।
So I think we are done with the lectures and the question and answers. Now I would like to request Professor Bodiuzaman sir to make a few comments. Bodiuzaman sir এইমাত্রই ছিলেন। Associate Professor Habibur Rahman sir, would you like to join and add a few comments?
Thank you. I enjoyed all the lecture and learned a lot. So I hope students will be benefited from this. But basic things should be remembered always. Not the higher thoughts, not universal for all. So stick to the basic things and basic questions. Thank you.
Thank you, Habib Bhai. Now I would like to request Professor Fazila Madam to kindly join us and make a few comments. Probably Madam.
শোনা যাচ্ছে?
Please. জি ম্যাডাম শোনা যাচ্ছে। জি ম্যাম শোনা যাচ্ছে।
শোনা যাচ্ছে না?
না শোনা যাচ্ছে ম্যাডাম।
শোনা যায় ম্যাম।
ম্যাডামের এখানে বোধহয় নেটওয়ার্কের সমস্যা আছে।
না ম্যাডামের
আমরা শুনতে পাচ্ছি।
ম্যাডাম হসপিটাল মনে হয়
না গাড়িতে। ইয়ারফোন নেই তো ম্যাডাম আমাদের কথা শুনতে পাচ্ছে না গাড়িতে।
শোনা যায় এখন?
জি ম্যাডাম শোনা যাচ্ছে ম্যাডাম।
সরি, সরি আমি গাড়িতে তো। সো থ্যাংক ইউ, আমি দেরি করে ঢুকছি, বাট মানে অনেক লাইভলি ডিসকাশন হলো। হারুন রে অনার্স মার্ক দিও, আর এরপর থেকে হারুন রে প্যানেলিস্ট হিসাবে রাখবা, হ্যাঁ, যাতে ও কোয়েশ্চেন করতে পারে এবং আমরা ওর আনসার শুনতে পারি, তাই না? সো নাইস ডিসকাশন। আই এম সরি আমি দেরি করে ঢুকছি, বাট থ্যাংক ইউ ফর কিপিং দিস আপ, and I hope that we can continue this, তাই না? And great presentation both by Shamim and by Nessar, and great discussion and very good questions by all of our panelists and faculty, Ashok, তারপরে Dhiman, তারপরে Habib. Thank you, and thank you for great moderation, Tawfiq. Thank you.
Thank you, madam. Thank you very much. So I think all the students are enjoying this program, and we have had back-to-back sessions on pacemaker. One was a live case, another was a live in box case. We tried to make it as easy as possible for you all to understand. And I'm sure if you come to the cath lab when the pacemaker procedure is going on, you will understand more about the tidbits you need to know during your exam. And this session also gives us an idea that we can have another session on ECGs related to pacemaker, its complications, and all these. So with permission from Fazila Madam, I would like to end today's session. All of
And thank you. And Tawfiq, just one word. Can Kolim upload these 2 sessions before the exams, because MD and FCPS cardiology exams will be held towards the end of this month. And I think these would help our students, right? If they can sort of go through these lectures again.
Okay, madam.
Yes.
Thank you.
And Tawfiq, I mean, that's also a great idea. Let's do the ECG session also just, next week or week after that, whatever works for Kolim.
Amen.
And thank you, Tawfiq.
Thank you, madam. So, so I would like to say Allah Hafiz from my side, and have a nice time, all of you. Sir, আমি তাহলে শেষ করে দিলাম।
Okay, thank you.
খুদা
Thank you.
হাফেজ, স্যার অশোক
Thank
স্যার।
Thank you.
Thank you.
Thank
Khuda
you.
Hafiz.
Enjoy
Allah Hafiz.
your evening. Ji.
জি,
Khuda
আল্লাহ
Hafiz.
No.